So now my talk is on subacute knee dislocation. So in fact, if we look into a topic called subacute knee dislocation, it's not really as a terminology called subacute. Either it's an acute or a chronic. Subacute comes into the layer in between around 3 weeks time, where patient has passed the 72 hours duration and it is within 3 weeks time. After 3 weeks, it becomes like a chronic dislocation. Now 3 to 6 weeks is okay. So let's talk on some, because we have covered everything, like somebody has covered PLC, somebody has covered PMC. MLKI is nothing but mixture of everything. Okay. So just start on some introduction, give a classification, how we examine and investigation and management. Okay. Yeah. So subacute knee dislocation is a clinical or radiological discontinuity in the tibia and femur. That's one way of reading it, and it's actually very rare. It's only about 0.02% of it. A nerve injury is seen in about 35% of patients. So remember that nerve injury can be very easily missed also. So there are two classifications: kinetic classification, sense classification, which are commonly used. It's the sense classification which is commonly used now. Kinetic classification, the sense classification, so it's like KD1, KD2, 3 and 4. 3 has got ACL, PCL and MCL means KD3M. ACL, PCL, LCL means KD3L. Okay, and KD4 is bicruciate and both collateral, and with fracture means KD5. So we are going to deal with only KD2, 3, 4, not the KD1. KD1 is a single ligament injury. Okay, so 50% of all knee dislocations spontaneously gets reduced. Hence, a kinetic classification is not very useful. Sense classification includes all those. So sense classification is very important for us. Okay, so in clinical exam, subacute knee dislocation, they are presenting after 72 hours. So vascular injury is not a concern because vascular injury has already been diagnosed. If it is 72 hours late, already vascular injury has been sorted out. Okay. Patient evaluation junction is mostly considered soft tissue condition, ligament injuries and neurological status. Thorough clinical exam is done to rule out any nerve injury, and specific tests are very useful, like Lackman antidote, everything all has to be done to document, which I give more weightage to the clinical assessment than MRI, because clinical assessment in UVA gives more information than MRI. MRI gives a guideline for you. So remember, a common pulmonary injury can have a permanent deficit in a lot of patients. So counsel the patients appropriately. And investigations do X-ray, MRI, CT scan, stress X-ray if needed. Not all the patients. Okay. If you have a doubt of it, then you can get stress X-ray also. Treatment, let's go in one by one with this. Operative versus conservative, or timing of surgery, whether repair or reconstruct, whether a single stage or two stage, choice of graft and sequence of tunneling. Okay. Can I treat conservatively? If they ask this question, there is no role for conservative management in a multiligament knee injury. You can have that in ACL, isolated PCL, you can have that, but in multiligament, all of the time it has been very well proven that surgical management works much better than a conservative management. So surgical management is a choice of procedure. Whether early or delayed surgery. Early surgery means by definition within 3 weeks time. So not to do it within 3-4 days, do it in around 10 to 14 days to 3 weeks time. That is called early surgery. Delayed surgery means doing more than 3 weeks. Okay, and it has shown that early surgery has shown to have a better functional outcome than a delayed surgery. So unless the time constraint, you try to do it within 3 weeks time from 10 to 14 days. That is gives a better outcome. Whether to repair or reconstruct. Anywhere you see an avulsion type of fracture or avulsion type of ligament injury, then repair will work if you do it in the early stage. If you are having a mid-substance, then you do repair plus augment. Then only the results are better than just repair alone. So this is the simple dictum to keep in the mind: mid-substance, repair and augment. If it is an avulsion type, you can just repair and see how it goes. LCL and PLC, intra-substance repair does not work very well. So you always augment LCL and PLC. Okay. So best to reconstruct PLC as repair has got very high failure rate. Especially for PLC, do reconstruction rather than just repairing. Whether to do a single stage or two stage, it depends on when you are seeing. The papers show that two stage procedures have a marginally better outcome than a single stage, especially in case of acute injuries. But if you see a patient coming in a chronic, like about 6 weeks or more than 6 weeks later, both of them shown a almost similar outcome. So if you want to do a single stage, then you should have a patient who is very good in doing rehabilitation. So you can do single stage unless they are very like athletes who are very good in doing rehabilitation, then you can go for a single stage. Otherwise, two stage also very well acceptable. Graft choice, allograft if we have, then it's useful, but in India we don't have allograft option very easily, so we have to use in this one only. But currently what we use is if we have MCL injury, then I try to avoid doing hamstring for that side. We can take hamstring from opposite side but not use hamstring on the same side, because hamstring also has shown to have a static stabilization function of the medial side. So not to use hamstring if you are having MCL injury on the same side. Surgical technique wise, no big difference between other ligament injury. For example, if it is a lateral side, we are only focusing on these three structures: LCL, PLC and popliteal fibular ligament, because these are shown to be the three main static stabilizers of the lateral sided injuries. Okay, though you have three layers, you are only focusing on these three structures. Okay, so this is an example of that. I think just skip these slides because already have been discussed. For LCL and PLC injury, you have to make 4 tunnels: 2 tunnels in the femur, 1 tunnel on the tibia and 1 tunnel on the fibula. So the landmarks have already been described, so no need to keep on emphasizing that. So always isolate the common peroneal nerve when you are doing the lateral side injury, because it's a chance that you can injure that. If you isolate from neck of the fibula right up to proximally and make sure you release the peroneal fascia also, then you are absolutely safe with the peroneal nerve injury at all. Actually, these are the drilling techniques for popliteus tendon, where you place your identify the posterolateral sulcus for the popliteus tendon and go just below the girdis tubercle in the tibia. So about 1 centimeter below the girdis tubercle, and make a drill hole and then pass a suture material through that, and then over drill for about 7 mm tunnel. Usually the 7 mm is the tunnel for the posterolateral complex. And for the fibular side, again you do the fibular head tunnel, where you pass from anterolateral to posterolateral. You can use a jig for that, or you can use a free hand, but you make sure you use a curette on the posterior aspect so that the drill doesn't overpass through or doesn't damage any of the structures over there. And in the femoral side, you have to make 2 tunnels apart about 18 millimeters anterior to that. Lateral epicondyle is 1 landmark, and then from there 18 millimeter anteriorly and slightly distally you make a tunnel for the popliteus tendon. So pass through about 40 degrees proximally, so that somebody was asking about how to avoid tunnel coalition. If you pass about 40 degrees proximally and anteriorly, then you can avoid tunnel coalition. So for the medial side injury, most commonly such as MCL is a very common damage. I think it's already been described, so I don't want to go too much about it. This is a case of MCL plus POL, so where you have in fact repaired both MCL as well as POL together. So just a quick word about tunnel coalition. Earlier people are asking about it. Remember, ACL is a structure which is more posteriorly placed in the femoral side. So when you are doing ACL and LCL or PLC together, you direct your drill anteriorly, not posteriorly. Then you will not go into the ACL tunnel at all. That is a simple dictum for those who are having ACL, LCL and PLC together. It's a good paper with these diagrams and all. It's actually available in literature very well about how to avoid tunnel coalition in when you are doing multiligament reconstruction. Same thing when you are doing PCL. Remember PCL is a very anterior structure in the femoral attachment side. So try to be in the posterior, and also it is a very distal attachment. So try to go more proximally when you direct it. Then you will avoid these PCL tunnels when you are doing further superficial MCL or a POL. Similarly, in the tibial side, MCL is a structure which attaches about 5.6 centimeter distal to the joint line. So you will miss ACL and PCL tunnel if you do correctly. So direct it distally, then you will not touch both ACL and PCL tunnel. ACL and PCL tunnel never merge together because they are in 2 different trajectories. If they are merging, they have done something very wrongly. You cannot merge ACL and PCL tunnels in tibia if you are doing in a correct steps. But with this I finish. The rehabilitation depends on concomitant injuries. Knee brace has to be applied for all the multiligament injuries, okay, with protected range of motion, protected weight bearing. Avoid external rotation and varus stress for lateral sided injuries. Avoid valgus stress for medial side injury. Start with the early isometric quadriceps exercise from day 1 itself from all the patients. Thank you. With this I finish this talk. So we have our conference Madurai Shoulder Knee Con, which occurs every year. This is the 7th year we are doing.